Well, hello. This is Robert with Welcome to Supervision. I am a Texas-based licensed professional counselor supervisor, and I am making these videos for my LPC associates. Welcome. You've probably been sent by me to watch one of these. You've probably seen several others already. And if you're not one of my LPC associates, then sit back and hopefully you get something out of this video as well. I've decided to make these in an attempt to convey as much information as I can from myself to others. This one is, as you'll notice, we're focusing on pharmaceuticals on this video. Going to be talking about some antidepressants. Now, I do want to point out this is not a full discussion of antidepressants. There is a whole lot more that you can learn about these things. This is meant to be kind of just a brief on the different medications that are out there in the antidepressant side of things. It should also be noted I am not an MD, I am not a pharmacist, I do not have a degree in chemistry or pharmaceuticals. I'm going off of what I know as well as what I've researched and put together for this video. The purpose of it is to help my LPC associates who do not have a medical background to get some insight into this. As I said, I would encourage you to look further into it. If you want to get continuing education on the various pharmaceutical aspects of mental health, then by all means, definitely do it. It will make you a better counselor the more knowledge you have and understanding. So having said that, let's go ahead and dive into this one. So we're going to be looking at antidepressants, like I said. In this video, we're going to be covering some of these basic questions: how they work, what they are, when they're used, why they're used, kind of the basics of antidepressants. Nothing real fancy there. You're going to notice my hands moving around. I got me a nice cup of tea. This office is freezing right now, so I'm using it. All right. So why do your clients need some antidepressants? Well, they're probably dealing with some depression. The World Health Organization states, I got a wonderful quote from their website: depression is a common illness worldwide with an estimated 3.8% of global population, including 5% of the adults, and those are 5.7% amongst older adults 60 years of age and older. Altogether, they've estimated this to be in a range of 280 million people globally dealing with depression. The American CDC, Centers for Disease Control, had some more information. In general, about 1 out of every 6 adults will be dealing with depression at some time in their life. And altogether, it affects 16 million Americans every year. That would be 4.7% of American population. That's a lot of people, okay? So if you look at the region, the greater Houston Metroplex area, that I believe in this region we have somewhere in the vicinity of 7 million people amongst multiple counties. That's a lot of people, and there's going to be a lot of need for these medications. The National Alliance for Mental Illness reports that approximately 21 million U.S. adults have had at least one major depressive episode just in 2020 alone. Now, I didn't go into detail as to the reason. I suspect, personally, it's my opinion, but I suspect that COVID may have been a part of that to have that number jump up, because that number differs a good bit from what the CDC reported. In any case, they go on to say that it affects all ages, all racials, all ethnics, all socioeconomic backgrounds. It affects everybody, okay? And so there is no one group that is excluded, but there are a few groups that have a higher hit on experiencing depression. Globally, some basics that we need to remember. The average is 3.8%, and that's roughly 280 million people around the globe. Here in the US, we're looking at that being 4.7%. and 1 in 6 adults for roughly 16 million Americans. When are antidepressants needed? Well, here again, let's go back to the World Health Organization. During a depressive episode, the person experiences depressed mood, feeling sad, irritable, empty, or a loss of pleasure or interest in activities for most of the day. That's an important aspect. It's a majority of a day. Also, you'll notice as we go on, it has to last for more than 2 weeks consecutive. Other symptoms can also include concentration problems, excessive guilt, low self-worth, hopelessness, helplessness, thoughts about dying or suicide, disrupted sleep, changes in appetite or weight, feelings especially tired or low in energy. Very common. Some of the things that you go to the NAMI website you'll find are depression can present different symptoms depending on the person. Some people actually will provide more physical symptoms, which would lead them to go to see their medical doctor, general practice, as opposed to a psychiatrist or a counselor. Also, the functionality of it, the day-to-day aspect, real important. 2 weeks. DSM-5 kind of has always held to that, even going back as far as the DSM-3. 2 weeks is kind of the general timeline. Some of these common symptoms include, and there's a good list, changes in sleep, appetite, concentration, energy, interest in activities, hopelessness, guilty thoughts, movement, how they function and move, the way they walk, physical aches and pains, and of course suicidal thoughts. So what are the types of antidepressants? There's actually quite a few, and we're going to be looking at them in a general basis. There will be one of them that we look at a little more in detail. The one in more detail will be SSRIs, the selective serotonin reuptake inhibitor. This one is the most common, and you will probably see more of it than any other. SNRI, serotonin noradrenaline reuptake inhibitor. The NASSA, noradrenaline and specific serotonergic antidepressant. TCAs, tricyclic antidepressants. You're going to want to remember that one. That one is a little bit tricky. The monoamine oxidase inhibitor. You're going to want to remember that one. That one is dangerous. And then SARIs, serotonin agonist and reuptake inhibitor. So most common, as I said, was the SSRI. And the reason you want to remember the TCAs and the MAOIs are the side effects and the possible complications of drug interaction, especially with the MAOIs. So let's kind of dive into the SSRIs for a moment. Currently, the FDA has them approved for certain specific conditions. There's quite a few of them. Major depression, generalized anxiety, bulimia, bipolar disorder, obsessive compulsive disorder. Notice that not the obsessive compulsive personality disorder, very different issue. Panic disorder, premenstrual dysphoric disorder, treatment-resistant depression, post-traumatic stress disorder. There's some things about that one that are still being researched. Social anxiety disorder. So, as you will recall in other discussions you may have had already with me, if not, we're about to, depression and anxiety, they go hand in hand. And if you've got one, you're going to have the other. They just work together. Okay, now there are also some off-label issues related to SSRIs. Off-label is a term that would be used by the medical field, indicating that the medication is being used in a way that it was originally not designed for, but does seem to have good effect. A lot of these: binge eating disorder, body dysmorphic disorder, fibromyalgia. There's actually a couple medications that really target that one. Premature ejaculation, paraphilias. There's some questions on those ones though. Autism, and then Raynaud phenomena, vasomotor symptoms associated with menopause. I'm not going to go into a whole lot of detail on any of the off-label use. Just recognize that sometimes your medications that your patients may have, they may be taking them, and it might throw you for a loop to look them up and go, okay, why are they on it? They're not diagnosed with depression. And then you find out they've got some other issue that the doc is using that medication for in that connection. Okay, so some of the names, there's quite a few of these. SSRIs, I want to look at the different types of names. Technically there are 3, but I'm only putting 2 of them up here. You have your brand name, and that would be the company that first came out with it. And let's look at fluoxetine, that would be the generic name. But there's also the chemical name. Often the chemical name is a little bit longer and it's less enjoyable to say, and so the brand name will make it simple. In this case, Prozac, and the doses are there for you to see. Feel free to make a copy of that, write that information down. You're going to see Prozac, Zoloft, Celexa, Lexapro. They're pretty common. Okay, you're going to see those ones on a regular basis, just because they're given out a lot. Okay, not just by psychiatrists, but primary care providers, GPs, pediatricians. These guys give them out a lot. So do the OB-GYNs, extremely commonly used. And the reason for that is they have very low side effects, which makes them so well accepted. So how do they work? Well, in the medical field, they would refer to that as a mechanism of action. Notice I am not an artist, and I didn't want to steal somebody else's artwork, but so I drew one myself and put it in here. What you're looking at there is the synaptic cleft between 2 nerves. You got the axon and the dendrite coming together, and the little space there allowing us to have the transfer of the biochemical. So in this category, let's look at a few aspects here. SSRIs inhibit the serotonin transporter at the presynaptic axon terminal. Very fancy way of saying that location. That's where it's happening at. It's in that little space between the 2 nerves. And it works by inhibiting the serotonin forming compound. In this case, it would be known as 5-HT. To pronounce that would be 5-hydroxytryptamine. You can actually purchase that substance over the counter at a pharmacy, and it's not bad. It might be helpful. I can't say. But the idea of this is that it helps to keep more of the serotonin in that space. You'll notice in the picture, if you can kind of zoom in on a little bit, that on the right hand side there are 3 little ports, and so and you'll notice the 2 bottom ones are blocked. So what basically, the way I describe this to my clients is that the serotonin, the blue dots in between the axon and the terminal of that synapse, they're floating in that space and they're doing their job. Well, the one side on the right is really good at recycling it and pulling it back in. And so what SSRI does is it goes in there and blocks it. It prevents the recycling, the reabsorption mechanism, allowing that substance to stay in there longer, thereby connecting into the other nerve side and releasing its transmitter to keep the mechanism working. Because if it's not there, all those blue dots in that space would get pulled back into the synapse, or out of the synapse and into the dendrite there, and pull it back in, preventing it from doing its job. So the whole idea here is that it stimulates the postsynaptic receptor for an extended period of time. That's all it does. And it does it by blocking and inhibiting its reuptake, its recycling. Okay, some side effects. Oh, and look, I missed one of those on my automation here. So that's all right. So one of the things you want to look out for is some cardiac issues, but we'll get to that in a moment. In 2004, the FDA issued a black box warning for SSRIs and other antidepressant medications due to a possible increased risk of suicidality amongst children and those under 25. Guys, this is real important. They've known about this for a long time. The main thing you want to look for there is if they run out of medication or just suddenly stop. You do not want your client going cold turkey off of this medication. If they start talking to you about wanting to get off of it, you have to send them back to their doctor to do it properly. They have to be tapered off of it and titrate down so that they are not going to go through that. There is a strong possibility that they will have suicidal thoughts, and you want to work with them to get them ready for those thoughts so that it doesn't catch them off guard. Some common side effects from SSRIs include sexual dysfunction, and that's a concern for many, especially if they are younger. They don't like that. Can't say that I blame them. Another one would be sleep disturbances, not getting enough sleep, getting too much sleep. That's why in your biopsychosocial, you're going to be asking those questions, getting a baseline of how they're doing already. Weight changes, that's a big complaint. A lot of people will usually gain 10 to 15 pounds in the first few months. A lot of that, here's my opinion, I think because they're getting rid of the depression, they're finding food to be enjoyable again, and so they start eating again. Here's another side effect that's kind of odd, the anxiety. Remember I said anxiety and depression do go hand in hand. So I'm not 100% sure that that one's a side effect or it's just already there and we're starting to see it. Dizziness, that one, you can get dizzy off of oxygen too. That one's a very common one for everything. Headaches, gastrointestinal distress and problems, xerostomia. Have fun, look that one up. I might have fixed it in here already, but just go look it up. Pause the show and go look it up, just because it's a fancy word and you'll never use it. They are also contraindicated, and what that means is there's times when they should not be taking this medication. If they are already on an MAOI, then they should not be on an SSRI at the same time. If you run into that, you might want to check with the pharmacist, the psychiatrist, the doctor, and just point out to the person, look, did you realize you're on these two medications? Have you talked to your doctor about them? They can have side effect combination problems. Other medications that increase serotonin level would put a person at risk for serotonin syndrome. Now, I do want to point out serotonin syndrome is extremely rare because the pharmacists are very good at spotting it and knowing if they're on the wrong medications. Here again, not everybody goes to the same pharmacist, and human error can happen, so you're a part of the chain to look after these folks and to make sure that their medications are working in the right way for them. SSRIs are more likely to influence some people's hearts. This one here, I'm digging back into my paramedic days of knowledge. A prolonged QT is an aspect of the cardiac cycle where the heart rhythm and rate is being controlled in the heart. I'm not going to go into a lot of detail here on this one for you because it's kind of extensive, but the doctors, the cardiologists, the paramedics that have the equipment, the EKG, they can spot those, but you have to have the right equipment. You wouldn't be able to do it any other way. It's more common than the serotonin syndrome, but there again, it's pretty rare. Okay, the biggest problem, suicidal ideation. Okay, that one can pop in, especially when it is suddenly removed from the body. This is probably the most dangerous aspect of SSRI, is if they run out, they don't want to do that. You really want to make sure that they stay on top of that. Most common side effect, of course, is dizziness. And like I said, serotonin syndrome is very rare, but you do also want to look out for the cardiac problem history. Okay, things are going to slow down a little bit here. Actually, I'm sorry, we're going to speed it up because the rest of these are kind of get simple. Serotonin noradrenaline reuptake inhibitors, very similar to the SSRIs. They are designed to be more effective antidepressants than the SSRIs. However, the evidence that SNRIs are more effective in treating depression is unclear at this time. It seems some people respond better to SSRIs, while others would seem to respond better to SNRIs. Here again, it's an issue where your client may say to you they feel like a guinea pig. And the fact of the matter is they probably do, because the doctors have no way of being able to tell how that substance is going to work until they use it. And so once a person finds the right one, then hey, they're off to the races. Things are going great. But until they do, it's a little bit of experimentation. They got to do a little trial and error. Okay, this one here is interesting in the sense that it also blocks the reuptake of neurotransmitter norepinephrine, hence the name. This one plays a vital role in alertness, motivation, heart rate, blood pressure, especially during stressful situations. So just be aware there are some things about it that is a little different. Not only is it blocking the reabsorption of serotonin, but it's also blocking the reabsorption of the noradrenaline, thereby giving a little boost of energy. It's one way to think of it. Okay, some of the names on this one, you're not going to get me to say a whole lot of those. I will say duloxetine, but the other ones I'm not even going to try to say. Duloxetine is Cymbalta. That one, you're going to see a lot more of it. That one or the Prestige. The two white ones there, the Fedzima and Savala, from my research, it looks like those ones are used mostly in Europe and the United Kingdom, whereas Prestige and Cymbalta are used here in the US. I have personally seen them prescribed a lot for pain management, fibromyalgia, more than anything else. You will find them for depression, but that Cymbalta has an amazing pain management response. So it gets used for that one a lot. All right, the noradrenaline and specific serotonergic antidepressants, there's really only one. It's not that special. You won't find it hardly ever. I think I've run across that one maybe couple dozen times in the last 15 years. It's got some really kind of odd side effects. Increased appetite, 17% of the time. People do gain a lot of weight on this one. That's probably the number one complaint you'll get from clients, where they're like, hey, this one really made me fat. They don't like that. It also can cause constipation, which would be a little depressing in and of itself. So this one is also oftentimes used off-label for PTSD. There again, I cannot go and speak effectively to that. I just didn't have the time to look into that one very deeply. Okay, the tricyclic antidepressants, the TCAs. Now we're getting into some interesting material. I'm not going to go into a whole lot of depth simply because there's a lot to this that's medical oriented, and I'm not a doctor, nor a chemist or a pharmacist, nor do I want to be. TCAs are a much older type of antidepressant. They're no longer usually recommended as a first-line treatment. They got some really dangerous overdose potential that's out there. That's why they got pulled. They can be overdosed with easily. There are some exceptions, however. Okay, people with some severe depression that other treatments just don't seem to work. Really, the TCAs work good for those. So basically, the doc is going to go with the SSRIs or the serotonin noradrenaline reuptake inhibitor, the SNRIs. they're going to go with them first. This will be like a third backup if nothing else works. Also, it does work really well, I've been told, for the OCD and bipolar disorder population. If you're wondering why the name Tricyclic, it's because of that. That one there is an image of imipramine, and you'll notice on the left-hand side the three little circles. That's what would be referred to, the reason it's called a tricyclic. It has those three little circles on the chemical chain. Just find that one kind of interesting so you have an idea of what it would look like. If you have a chemistry background and you're undergraduate, then this would make a whole lot more sense to you. I don't. Okay, some of the names you will run into. Some of these I have personally seen used, and for some people they work really, really well. For others, not so well. Elavil, most commonly, I've seen that one prescribed a bunch, but that was 20 years ago. Don't see it hardly anymore. Anafranil, saw that one a good bit. The rest of them, Pamelor, I ran into that one a few times working at different hospitals, but the rest of them you won't hardly see at all. The one there in the middle, Dofepin and Prothioidin, only used in the UK, as is the Lofepramine. In fact, I could not find a brand name for that one. That was the only name that I could find. And that one was only used in the US. It has a major drawback, though, of sudden onset suicide. So go figure that one. You know, it's kind of funny when you have a substance that's supposed to help one thing, but it causes the same thing at the same time. That's why a lot of the TCAs, they're not used anymore. They had some really weird side effects. I mean, if you look at those, blurred vision, drowsiness, constipation, sexual dysfunction, and the list goes on. Excessive sweating, I've seen that one, where a person's just constantly sweating. Disorientation, confusion, difficulty urinating, liver problems, and of course the sudden onset. MAOIs, monoamine oxidase inhibitors, you won't hardly see these ones at all. These ones have some really nasty side effects. Let's look at those primarily. Drowsiness, rapid heart rate, weight gain, irregular heartbeat, constipation, seizures, sexual dysfunction, blurred vision, and difficulty urinating. Now I remember in the 90s when I was a paramedic that that was a common medication that was used for depression, and it had a lengthy list of substances we could not provide to a client during a cardiac arrest or other problems. We were constantly having to ask people, what medications are they on? Nardil, that was the one I saw the most back in that time period. Today, I don't think anyone's prescribed that hardly anymore at all, but you may run across it. I can't say that you won't, but it's possible. Serotonin agonist and reuptake inhibitors, SARIs, not usually a first choice for an antidepressant. The SSRIs would be in that category, but they do have some side effects. Oftentimes this one is used off-label for sleep. I've seen that one used a lot for sleep. The 50 milligram trazodone is a very common sleep agent that is being prescribed nowadays. It has a few side effects: irregular heart rate, some fatigue, difficulty urinating, dizziness. They're short-lived is what I'm being told, but at the same time, low dose, less damaging, less side effect potential. Most of the time it was for sleep. They would take it in the evening and not in the morning. So that's the other aspect I want to mention to you. You will run across a whole lot of the terminology being the medication name, the dose, and then the letters PO. That's an abbreviation for nursing, meaning per oral. In other words, they got to take it orally. Followed by that would be the number of times per day. So you'd see a medication name, Prozac, 25 milligram PO Q day or QD. You might also see TID or BID, meaning for twice a day, 3 times a day, that kind of a thing. In some cases, you may see an abbreviation that has the small letter I with a little dot over it, meaning 1 tablet, 2 tablets, 3 tablets, so many times per day. You may see that kind of abbreviation if you're looking at medical records. Any case, okay, so we're kind of wrapping up here. I want to point out that this again was not meant to be a very in-depth look at antidepressants, but it is one to get you kind of started. I highly encourage you to investigate more about these medications as you get your clients base, as you get your caseload coming in. When you run across a medication that you don't know very well, by all means look it up. There are, by the way, some excellent apps you can put on your smartphone that, do they even call them smartphones anymore? I don't think so. They're just phones. But I use an app on mine that has an extensive list of psychiatric medications in it that I can very quickly see what the common dose is, what the names are, what the side effects are that I should be aware of, and what is commonly prescribed for. There's several really good apps out there that are free. I highly encourage you to get those. Okay, so again, I want to just sort of wrap up saying welcome to Supervision for those of you that are one of my LPC associates. I hope this has helped you open up some information about these substances and these medications and the prescriptions that you'll be running into. Again, this is not meant to be a complete class on antidepressants. There's a whole lot more to learn if you want to go into it. And again, you really should. This is a field that requires us to maintain our knowledge base and constantly learning new things, because just when you blink, they're going to come out with a new medication and you'll be like, what is that? I don't know that one. And so we have to look it up. So until next time, guys, keep doing what you're doing and let me know if you're having any problems on cases. We'll see each other in our face-to-face supervision. But until then, take care.